do the introduction and then we can start from there.
Okay. Welcome everyone to the Oxygen Therapy and Critical Care case-based series. Today we are presenting session number 8, Pediatric Considerations for Oxygen and Critical Care. As usual, we are grateful to have the following panelists: Dr. Eugene, Dr. Jean-Paul, Dr. Celestin, and Dr. Alain. Thank you. And with that, I will hand it over to Dr. Eugene to get us started.
Thank you very much, Alana, for good introduction. And thank you for everyone to join our session today. So can you hear me?
Yes.
Very good. So I'm going
Yes, we do.
Yeah, I'm going to try to share my screen and then we'll start in a few seconds. Okay. I don't know, can you see my screen? Okay. So the plan for today, we're going to talk about pediatric consideration for oxygen and critical care. So before we start, I would like to let Jean-Paul maybe make a few comments, and the people, if they have any suggestion or question, they can put that in the chat. Then we'll start in a few seconds. Jean-Paul, you can introduce yourself and make a few comments before we start.
Thank you, Eugene. I'm happy to be with you in this interesting session, and I would welcome everyone to follow carefully this session because it's very important to anyone. So without delaying, we can start.
Thank you very much. Let's start. So before we go in details, I need to remind our team that pneumonia is the leading cause of death in the children under 5 years, especially in the low-income countries. So those are the reports from the WHO. So for example, every year, over 5.9 million children die, mostly from preventable and treatable diseases, and more than 95% of those deaths occur in low-income countries. And pneumonia, as I said, is the leading cause of death, and it is responsible to about 18% of all death in this age category. So this will be very relevant for our discussion today. So for example, in 2010, there were about 120 million episodes of pneumonia in children under 5 years. And among those, 14 million progressed to severe disease and 1.3 million died. And hypoxemia was very common, and the fatal complications and increased high risk of death. So it is estimated that at least 13.3% of children with pneumonia would have hypoxemia. And that's about 1.8 million cases of hypoxemic pneumonia each year. So that's why it is very important for us to be able to manage the pneumonia. Sorry, I lost my screen here. Give me a second. Okay, I hope you can see my screen again. Very good. So I wanted to talk about pneumonia because it's a big problem, And by the end of this discussion, we'll be able to manage well those patients. So what are the objectives for today? So first, by the end of this session, we need to be able to know various oxygen supply options for various pediatric healthcare settings. And second, we need to be able to know various oxygen delivery devices available for pediatric patients, especially in our hospitals. And remember, this will reinforce what we have been talking about oxygen delivery devices for adult patients and also the oxygen supply option available to us. So we need to be able to recognize safe SpO2 goals for various pediatric patient conditions. We need to be able to understand and treat pathophysiologic conditions leading to hypoxemia in pediatric patients. We need to be able to recognize hypoxemia during clinical exam of pediatric patient, and we need to be able to understand diagnostic considerations for pediatric patient with hypoxemia. We need to be able to appropriately prescribe for pediatric patient, and we need to be able to implement appropriate therapy for pediatric patient with hypoxemia. So we need to have an interactive session. So we'll be asking questions, and please you participate by answering in the chat. So let's start with the case. We have a 6-year-old male with no significant past medical history presenting at the emergency with wheezing and increased work of breathing. So the symptoms started 12 hours ago. He has been less active for the past 24 hours by his mother report. So his mother also described 5 days of fever with maximum temperature of 39.3. He had a respiratory viral panel and the COVID-19 tests were negative. So he has also no respiratory symptoms. However, his mother does report that eyes were red and he has redness and swelling of his hands and palms. She also reported that today his eyes are swelling. So the patient aunt lives in the same house and had COVID-19 3 weeks ago, but the only symptoms was anosmia or loss of smell. So that's the history you have, and keep that in mind. So a brief history, the child was born at 32 weeks by vaginal delivery, and also the mother had severe preeclampsia. So the child spent 4 weeks in NICU for feeding and growth. So no CPAP machine or mechanical ventilation was needed. He has no other past medical history, and he had appendectomy 2 years ago. He lives with parents and grandparents and paternal aunt and uncle. And you remember that the aunt had COVID-19 3 weeks ago. So the vaccination is up to date, except for influenza. So that's the case we have. Let us keep that in mind. So let us start with the first objective, which is oxygen supply. So what are the oxygen supply options do we have in our settings, especially for pediatric patients? So let's start with the first question. Please list 4 sources of medical grade oxygen and how. Yeah, I need just to know the source of medical oxygen we have in our hospital. You can list 4 in our chat. You have about like 30 seconds. And please jump or feel free to jump in anytime. So people are very quiet. What source of oxygen do we have? Okay, yeah. Eugene is saying they have oxygen concentrator, they have mirror oxygen, oxygen cylinder. That's good. Okay, yeah. And Gabriel has also oxygen plant. That's good. Very good. So because we have been discussing about this topic in the last few sessions, we'll not spend a lot of time on this. There's a good resource which will be sent to you at the end of the session, but also Alana, if she has access, she can send the reference to this question in the chat. Thank you very much. So let's answer the second question. So which of the following oxygen sources are available to your facility? So you can answer in the poll here. Okay. Here is the question. So which row of oxygen delivery devices do we have? The nasal cannula, mask with reservoir. Very good. So what I see is that we have nasal cannula and mask with reservoir and probably simple mask as well. Okay, very good. Okay, let's go back to the case. So now we have vital signs for our patient. So the temperature is increased, 39.3. The heart rate is increased, 135 beat per minute. And the blood pressure is 70/32 with a MAP of 45. The respiratory rate is 35 and the oxygen is low. Saturation is 88% on the room air. So the objective for this part of the session is to know the various oxygen delivery devices available, and you have already answered some of the questions. So for this particular patient, what device will you use? Yeah, you can answer that in the question in the chat. So what device will you use and how much oxygen will you give? Okay, Gabriel is saying he will use a nasal cannula. How much? Seems like Gabriel is thinking 70 liters per minute. Yeah, I will ask Jean-Paul to talk about like the maximum oxygen you can give by nasal cannula.
Yes, Eugene.
Okay.
When you are using a nasal cannula, actually, the flow should be from 1 up to 4 to 5 maximum. When you go above 5, you are doing nothing because you are harming the patient. So it's the flow should be ranged from 1 to 4. Even 5 is acceptable. Thank you.
Yeah, thank you, Jean-Paul. So remember, if you give her like more than 5 liters, you are causing it's not very comfortable for the patient, but also there's irritation and the humidification is decreased, and then that's why you have like thick secretions from the patient, and they may have like upper airway obstruction. So um, I think the good rate should be between 1 liter up to 5. Sometimes we go up to 6, but in my usual practice, I go from 1 to 4. And if they need more, I will change and go to a mask. Okay, very good. Let's see what people gave. Yeah, nasal cannula 6 liters. Okay, very good. I think that's reasonable. Let's see what happens. So once you have already chosen to give oxygen, 4 liters by nasal cannula, and the oxygen saturation has increased to 92%. That's the situation now. Then let's talk about the pulse oximetry. We need to set the target for pediatric patients. So in order to do that, let us answer a simple question here. Yeah, so which one of the following statements are incorrect? So you can answer that in the poll. So the first one, all infant below 32 weeks or weight below 1,250 grams, and any who receive oxygen therapy should be screened for retinopathy of prematurity at 4 to 6 weeks. That's one. So newborn infant requiring oxygen therapy should have SPO target above 88% but below 95. Apnea leads to bradycardia, which further reduce oxygen delivery. The neonatal ventilation support should be administered with bag mask ventilation and 100% FiO2. So what is the correct answer? Okay, yeah, most of the people got the right answer, which is D. So D is the incorrect statement. So the first one is true because all those patients, they are at a high risk of retinopathy of prematurity if we give too much oxygen. So it's good to screen for retinopathy at 4 to 6 weeks. And the SPO target between 88 and 95% in newborn is good because they still have high fetal hemoglobin and low saturation because there is high affinity of oxygen for that. So apnea leads to bradycardia. That's a correct statement. And you can do ventilation support for children with FiO2 less than 100%. That's why that is incorrect. Okay, good. So the correct answer is D. Let's see the second one. True or false? True or false? So where pulse oximetry is not available, oxygen delivery, oxygen should be given to all neonates who have cyanosis and the respiratory rate above 70, who are too sick to feed. Is it true or false? Okay, very good. Yeah, very good. I think most of the people got the right answer, which is this is true. So if the patient has cyanosis or tachypnea, which will be defined by respiratory rate above 70, or they are too sick to feed, those are signs of respiratory distress, then they need oxygen. So good job. So let's see the next question. So true or false? In children living at high altitude, so at more than 2,500 meters above sea level, the normal oxygen saturation is lower than living at sea level. And at the level of SPO, at that level, SPO2 such as below 87 could be used as a threshold for giving oxygen. Okay, yeah. Most of the people also got the correct answer. So people living in altitude has a lower saturation. So the threshold for SpO2 can be lower at around 87%. So what are the areas in Rwanda with high altitude? Just a simple question. People can put that in the chat. Which areas in Rwanda have high altitude? Where this can be applicable? I just have one example. And Jean-Paul is welcome to share the example after they put the questions in the chat, if he has one. Yeah, that was my example. Thank you, Carissa Bernard. So volcano area. I think, yeah, like the Virung Park, a good example.
Also, we have the western part of Great Congo Nile. This part also is considered as like a high altitude, but the mostly one is in the northern province. This is where you have the higher altitude, as you mentioned.
Very good. So let's see the next question. So true or false? Children with respiratory distress living at below 2,500 meters above sea level receive oxygen therapy if their oxygen saturation is below 90% as measured by pulse oximetry. Yeah, this is the opposite of the previous question, and I see that most of the people are getting the right answer. So for the regular areas, the cutoff for oxygen therapy is a saturation below 90%. So most of our country will be like, our target will be 90%. Very good. Good job. So give me a second so that we go to the next question. Yeah, so the next question is true or false? Oxygen should always be given intermittently, such as every hour or two, and it should not be administered continuously in order to conserve oxygen supply. Yeah, most of the people got the right answer. This is false, as you can imagine, because you need to have like patient safety comes first over the cost. Okay, let's see what happens with our patient now. So our patient remained tachypneic with nasopharynx, intercostal retraction, but slightly improved on SpO2 at 92% on 4 liters by nasopharynx. So you have many differential diagnoses. Probably I will ask you differential diagnosis. So what are your top 3 differential diagnoses for this patient? You can put that in the chat. Okay, I'm still waiting for your answers. So what are your top 3 differential diagnoses? Okay, yeah, Dylan Umutoni, nice. Asthma, bronchitis. The patient has fever, has also signs of respiratory distress, with history of being in contact with someone with COVID-19 3 weeks ago. What are your top 3 differentials? COPD, Carissa, Bernard, Diana Omutoni, okay, COVID-19, okay. Yeah, those are good differentials. Foreign body aspiration, pneumonia, COVID-19, okay. Yeah, pneumonia, bronchitis, bronchiolitis, COVID-19, okay. Severe pneumonia. I think we have a good list there. Foreign body as so someone who put like foreign body aspiration. Can you elaborate on that? What are like the signs or anything like leading to foreign body aspiration? And the COPD, probably Jean-Paul can make small comment. How often is COPD for children? Because I don't want to answer that, but probably if Jean-Paul has a comment on COPD, he can make one. Because for me, that will not come among my top differentials.
Excuse me, Eugene.
Yeah.
It seems that my network was not on. Could you come back on what you commented on?
Yeah, thank you, Jean-Paul. So I saw people had like top differentials for our patient, and they have a good list, including asthma, bronchiolitis, bronchitis, pneumonia, and foreign body aspiration. Someone also talked about COPD, and I was saying, if you have a comment about COPD, because I don't think it is common in children.
Yes. Actually, I do agree with among of the differentials they mentioned, but the less likely is COPD because COPD is not common in children of such age. COPD is less likely to be present because if they understand is chronic obstructive pulmonary disease, mostly it is common in adults, mainly the smokers or these people who has chronic long-standing asthma or other disease where they have difficulty to eliminate CO2. Actually, COPD is not acute, it's a chronic condition. Less likely that this patient, our patient is having a more acute situation than a chronic situation. That's my comment.
Yeah, thank you, Jean-Paul. For really, COPD is diagnosed in people like mostly smokers or like people who have occupational exposure to dust, things like that. Then they develop chronic bronchitis, and then they have chronic cough. And if they have more than 3 months of chronic cough for the 2 consecutive years, then they are diagnosed as COPD, and they have signs of obstructive disease, lower airway obstructive disease, and they will need to have some bronchodilators, and also they will have to have some steroids to manage their chronic problems. And on top of that, they may have infections. Okay, very good. So I think we have a very good list, and thank you for doing a great job. So let's see the differential diagnosis. So again, they put asthma, reactive airway disease, foreign body aspiration, bronchitis, COVID-19, pneumonia, upper respiratory infection, congestive heart failure, multisystem inflammatory syndrome in children, cystic fibrosis, mediastinal mass, tracheoesophageal fistula, primary ciliary dyskinesia, laryngomalacia, gastroesophageal reflux disease. Okay. Yeah, but I think we have a good list, and thank you for that. So let us talk about the pathophysiology of hypoxemia. And we have been doing this for the last few sessions now. And the goal for this part of the session is to understand and be able to treat pathophysiologic conditions leading to hypoxemia, especially in the pediatric patient. So let's start with a simple question. So list 4 diseases of hypoxemia let us list 4 diseases of hypoxemia in the neonate. So you have about like 30 seconds. So I will wait for your answers in the chat. Then in the meantime, I will be opening the answer. Okay. Yeah. Please consider the age. So I'm just asking like causes of hypoxemia in a neonate or like children of less than 28 days. Okay, Dina is answering pneumonia, upper respiratory infection, asthma, bronchitis. Yeah, fetal distress. Okay, very good. Yeah, who has done a rotation in NICU? Yeah, we're just asking like hypoxemia in like neonate, uh, like children who were born like in less than 4 weeks. Yeah, very good. Patrick Niha was put like most of the answer. So they may have neonatal sepsis. Yes, they can be premature, and they may have transient tachypnea of newborn. That's good. TTN, and what else? So what happens once they are premature and then um, they don't have mature type 2 alveolar cells? What happens with that? What is the disease causing inability to have sufficient surfactant? Okay, yeah, it's respiratory distress syndrome. Okay, good. I think we have a good list. So neonatal sepsis, prematurity or respiratory distress syndrome, transient tachypnea of newborn. That's a good list. So let's see the answer here. Esophageal fistula, that can happen as well. Okay, we go to page 8. Okay, so a number of conditions can lead to hypoxemia in neonates. So notably respiratory distress syndrome, BF asphyxia, transient tachypnea of the neonate, and pneumonia is also very common. So, and also some babies are not well because of prematurity, sepsis, seizures, hypoglycemia, and that can lead to apnea as well. Apnea and hypoventilation, that also can cause hypoxemia. Okay, those are the causes of hypoxemia in neonates. Okay, let's move to the next question, which is hypoxemia in children. So let us define children as if they have age above 1 year. So what are the common causes of hypoxemia? So good job so far. Yeah, Emmanuel Matagoma. Okay, membrane disease. Yeah, that's the respiratory distress syndrome. Good job. So let us answer the next question, which is, what are the 4 diseases of hypoxemia in children? Okay, very good. I see people are answering now. Severe pneumonia, sepsis, ARDS, congenital heart defect, heart and lung conditions, rare injury. Can you be more specific, please? Because there is a long list of heart and lung conditions. So cerebral malaria, yeah, that can lead to hypoxemia, prematurity. This is in children. So think about something happening in children of 1 year and above. So ARDS, pneumonia, funny body, that's good. So we have a good list. Let's see the answer again. Go to page 8. Very good. Yeah, so the top cause of hypoxemia may include infections, acute respiratory infection, including pneumonia, for example. And the common cause of pneumonia in children are Streptococcus pneumonia and Haemophilus influenza, viruses as well, including respiratory syncytial virus and influenza virus. You may think about a high-risk group, including malnourished children, children of HIV, and people with TB. Very good. So let's see other causes as well. Okay, you can have superinfection in a patient with asthma, meningitis, the sepsis, but that is less common in comparison to pneumonia. But keep in mind that asthma patient may develop like superinfection. Again, as you said, children with heart failure and other cardiac abnormalities, anemia, and carbon monoxide poisoning, trauma, and perioperative emergencies. Malaria also is a consideration, and that's a good list, I think. Very good. Yeah. So let us remind ourselves the pathophysiology of hypoxemia. And remember, hypoxemia is low oxygen concentration in the blood, and that can occur in 4 different ways. So you can have low level of oxygen in the alveoli. You can have impaired diffusion at the alveolar capillary membrane, and then you can have impaired oxygen binding to hemoglobin, or you have vacuum mismatch, ventilation perfusion mismatch. So those are the 4 common pathophysiological conditions. So let's start with the first one. Can you please answer, like give us examples of 2 causes of hypoxemia due to low oxygen in the alveoli? I think the question is clear. So what are the 2 causes of hypoxemia due to low oxygen in the alveoli? Obstruction of respiratory system, that's very broad. Okay. Yeah, let's like take a look on this figure. So as you can see, there are multiple reasons, as we said, which may lead to hypoxemia. So now we're talking about low oxygen in the alveoli. So you can have 2 reasons, either hypoventilation, meaning someone is not like removing the CO2, or you are giving raw FiO2. So for example, you forget to open the oxygen, or you are giving a another gas which is not oxygen, for example, or you are at high altitude. So all those things which either you are not eliminating CO2 or you are not giving enough oxygen, those can be the 2 reasons you don't have enough oxygen in your alveoli. So, and let's start with hypoventilation. And the best way to think about it is it a central cause or peripheral cause? So a central cause, for example, you have like intoxication, for example, or poisoning, which will decrease your GCS, and then you have CNS depression, and your respiratory center is not working. So a good example is too much opioid. You give too much morphine or too much fentanyl, for example, or too much midazolam. Then peripheral reasons may be either to your muscles or nerves. So if the muscles are affected, for example, in Guillain-Barré syndrome, then you can't eliminate enough CO2, and that will lead to hypoxemia. Or you have injury to the nerve. People with spinal injury or phrenic nerve injury. So, I mean, high C-spine injuries like C3 or C4, then your phrenic nerve injury as well. Then you are not, your diaphragm is not working, you are not ventilating properly, we retain a lot of CO2. And chest wall issues, if once you have like flare chest and chest trauma, those are good examples. The example of low FiO2 I gave is high altitude. Very good. So that's the answer for the first one. So let's see the next question. What type of poisoning leads to ineffective binding of oxygen to hemoglobin? In what setting is this poisoning at a risk? So think about that. So the next question, what type of poisoning leads to ineffective binding of oxygen to hemoglobin? So in other words, what is the poisoning which will replace oxygen, which is being bound to hemoglobin? In what setting is this poisoning a risk? Yeah, Emmanuel Mutagoma, yeah, and Dina Rutikanga. Yeah, you got the right answer, which is carbon monoxide poisoning. That's good. And that will replace oxygen binding to hemoglobin. And it's most commonly seen when there is um, fire in closed space. Very good. Okay, let's go to the next question. Um, list 4 causes of VQ mismatch, of ventilation perfusion mismatch. So what is this? So you have areas in the lungs where you have either areas which are well ventilated but not well perfused, or in the other side you have areas which are well perfused but not well ventilated. So what are the common causes of that? Yeah, asthma is one of them. Very good. COPD, that's good. Cyanotic heart diseases. Okay. Yeah, we have a good list. So COPD, asthma, um, heart diseases. Okay, vacuum mismatch. So let's see the answer. Okay, so you have COPD, you have asthma, you have interstitial lung diseases, and you have pulmonary embolism. Okay, those are the causes of PQ mismatch. And the good thing is that they can be corrected with oxygen. If you give oxygen, the patient can get better. So, and then that brings us to the, before we finish, let's think about the cause of shunt. And shunt means that you have areas of the lungs which are well perfused but not well ventilated. And the way I think about it is that you have something which is filling the alveoli, either fluid or pus or collapse. So those examples are here. And those patients, there's no improvement with oxygen. So physiological causes like pneumonia, you may have atelectasis, pulmonary edema when you have increased fluid in the alveoli, pneumonia, you may have even pus in the alveoli, atelectasis, you have a collapsed alveolus, and acute respiratory distress syndrome, which is a spectrum and a complication of most of these. Very good. And anatomical causes, you can have intracardiac shunt, where you have non-oxygenated blood coming to the lungs. Very good. Okay, good job so far. Let us take a look on the progress of our patient. So our patient remains tachypneic with stable nasal flaring and intercostal retractions. Those are the signs of respiratory distress. So white blood cells 2,000, platelet 110,000, CRP 13 milligram per liter, ESR 80 millimeter per hour, and the chest X-ray shows bilateral multifocal ground glass and consolidative airspace opacities, cardiomegaly, and bilateral pleural effusion. Those are the signs of pneumonia. So what is your differentials? Now we are ruling out asthma, reactive airway disease, and foreign body aspiration. So the top, you include bronchiolitis, bronchitis, COVID-19 pneumonia, congestive heart failure, and multi-system inflammatory syndrome in children. So let's talk about the clinical exam. Okay, let's talk about the clinical exam. So the goal is to recognize hypoxemia with a clinical exam in pediatric patient and understand diagnostic considerations for pediatric patient with hypoxemia. So let's start with the video. And then we'll see the common signs of respiratory distress in children.
So I looked up asthma and it said C, C. Well,
Okay, I don't know if you can see my screen. So let's see this patient again.
So I looked up asthma asthma and it said C, C. Well, it just said C medical card. You can't.
Okay, yeah, you can tell me what you saw. What are the signs of respiratory distress did you see in this patient? You can at least put like 2 signs in the chart. So the patient has cyanosis, what else? Okay, yeah, tachypnea, what else? Wing there. So what kind of congenital malformation did you see? Difficulty in breathing, okay. So we have a good read. So the patient will have cyanosis, tachypnea or increased respiratory rate, difficulty in breathing. We are missing like use of accessory muscles. We have like subxiphoid retraction, this patient. We have head nodding and we have decreased level of consciousness. So those are some of the signs I saw for this patient. And there are some recommendations for the WHO on how to recognize hypoxemia in children. So, and as you can see in this table, so the pulse oximetry is the gold standard. So it's recommended for determining the presence of hypoxemia and for guiding administration of oxygen therapy to infant and children. So strong recommendation, even if there is low quality evidence. The second recommendation by the WHO is um, use pulse oximetry whenever possible for detection of hypoxemia in children with severe lower respiratory infection. And if pulse oximetry is not available, like watch for the following signs, including central cyanosis. You can look on the tongue, for example, and compare the color of the tongue to the color of the mother's tongue. You can look for nasal flaring. You can look for inability to drink or feed, and grunting with every breath, and depressed mental status. The patient may be drowsy or lethargic. In some other situation, uh, you can have very specific sign, including severe low chest wall indrawing or subxiphoid retraction, as what I said. And tachypnea is what you said, which is very good. once the respiratory rate is above 70 in children, and you have head nodding. Very good. So, however, there are some challenges in examining a pediatric patient for hypoxemia. I don't think we have a lot of time to go in those details, but we'll share the resource from the WHO, and you will see that most of the signs are non-specific. That's the challenge. So there are multiple reasons a patient may have tachypnea, for example, or, or they can have tachypnea, but they don't have low saturation. So without pulse oximetry, there are many patients you can give oxygen, even if they don't need oxygen. That's the challenge, because most of the signs are non-specific to hypoxemia only. So, but for details, you will use the resource we share in the chat and also after this session. Very good. So let's see the update for our patient. For now, the temperature is 38.9. The pulse is 133. The respiratory rate is 30, and the blood pressure is 77/38. SpO2 is still 92%. Physical exam, weight 20 kg. The patient is ill looking, drowsy, but arousable, and moderate respiratory distress. The patient has bilateral conjunctivitis, but no discharge or scleroicterus. The patient has mild periorbital edema without erythema, and the patient has nasal flaring, uh, slightly swollen mucous membrane, and strawberry red tongue. The patient has increased work of breathing with use of accessory muscles, and both intercostal and suprasternal retractions. The patient has crackles at both lung bases with intermittent wheezing, and a prolonged expiratory phase. So no stridor or signs of upper airway obstruction, no labs, no good, and good air movement. For cardiovascular, the patient has tachycardia, regular rhythm, normal S1 and S2, no murmurs, and pulses are weak, and capillary refill time is more than 3 seconds. So the patient may be dehydrated. So the patient has a hepatomegaly of 4 centimeters below the costal margin. Very good. So for extremities, the patient has no edema in the nose cyanosis. The patient has also in the skin erythema bilaterally, no rashes, poor skin tagger, as you said. So that's a lot of information. And from that, we just have one question. What are the signs of, what are the emergent signs of, or signs of impending respiratory failure? Yeah, just in general, just if you can give us a list of signs of impending respiratory failure or danger signs in the patient with hypoxemia. Just to give us two signs of respiratory failure or danger signs where you will need immediate intervention. Okay, very good. So someone said decrease the level of consciousness. I think that's fair. The saturation, that one, the saturation is very low. What else? Tachypnea. Okay. Yeah, let us look on the answer. Yeah, you can see the right answer on the left side. So there are emergency signs which may include obstructed or absent breathing, severe respiratory distress, central cyanosis, signs of shock when the patient has cold hands, capillary refill time above 3, high heart rate with weak pulses, and low or unmeasurable blood pressure, coma or serious reduced level of consciousness, convulsions, signs of severe dehydration in child with diarrhea, lethargy, sunken eyes, very slow return of the skin or after pinching, or any two of these. So those are a summary of the danger signs, but I think you got most of the signs. Very good. And as you can see, our patient has some of these signs. Okay, and that brings us to the next interesting question. How can you distinguish between the respiratory distress and the respiratory failure? So before I show the answer, I would like to see what you think. What is the difference between the respiratory distress and the respiratory failure? Yeah, okay. I will show the video to show the difference, but in my own experience, when someone has respiratory distress, they are in a compensation mode. So what means they try to increase the respiratory rate and they increase the respiratory effort to meet the oxygen need. So in the respiratory failure, the compensation has failed. So now the effort is not meeting the basic oxygen need. And then either the respiratory rate will decrease, and also the GCS will go down. And that failure, because they can't meet the metabolic needs. So that's my own way of differentiating that. But let's see the details in this video.
Eugene, I have a comment on respiratory failure.
Please go ahead. I have stopped the video, so you can go ahead.
Thank you. So the respiratory failure, as you mentioned, I do agree with you that respiratory distress, it's a process of compensation where the demand and the supply, there is imbalance. There is imbalance between supply of oxygen and demand of oxygen. That's why even you can easily understand distress. The body is distressed to get the balance between the demand and the supply. For respiratory failure, as you said, just this is the final step where the compensation has overwhelmed. But respiratory failure, you have to know that there are two types of in respiratory failure. There are two categories. There is a problem which might be related with oxygen, the low oxygen which is coming in the body, that may lead to respiratory failure. It might be also the problem of CO2, when the body is not able to clear out CO2. So our audience, I want you to know that respiratory failure, it might be hypoxemic, it might be also hypercapnic. So the issue of CO2, when the body is not able to clear CO2, or if it's hypoxemic, it's the problem of oxygen content in the body. So thank you.
Thank you very much, Jean-Paul. So let's see watch this video. Also see another explanation.
Recognizing Respiratory Distress and Failure by Dr. Monica Kleinman.
When we say respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do, and sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned, has transitioned from respiratory distress to respiratory failure, and may progress to respiratory arrest and cardiac arrest.
Okay, I hope that was helpful to show the difference between respiratory distress and respiratory failure. So let us talk about the management, and then we'll be towards the end of our discussion. So the goal for this last part is to be able to prescribe appropriate oxygen therapy for pediatric patients and implement appropriate therapeutic options for pediatric patients with hypoxemia. Again, let us always go back to our basic approach. For patients with hypoxemia, we need to remember to open the airway, check the pulse oximetry, start oxygen therapy, have an IV for that patient, suction as needed, and EKG monitoring as needed. So for our children, we have already given a bolus of normal saline 20 mg per kg. We have given antibiotics, paracetamol. The temperature is decreasing to 8.4. The pulse oximetry showed a heart rate of 125. Respiratory rate is 32. The blood pressure is okay, 81/42. But SpO2 showed a raw saturation of 90% and 4 liters of nasocamine. So the physical exam is unchanged, with the exception of moist mucous membrane. So just let us remember the classic clinical presentation of upper airway obstruction, which may include stridor, which is a high-pitched noise, respiratory noise. We need to think about other etiologies of upper respiratory, upper airway obstruction, and also interventions. So I would like to hear from you, like your top differential diagnosis once a patient has like a stridor and signs of respiratory upper airway obstruction. So what will be your top like 3 differential diagnosis? I hope the question was clear. So what are the common causes of upper airway obstruction? Okay, yeah, laryngeal abscess. What else? People have been like talking about a foreign body, for example. That's another cause. What else can cause upper airway obstruction? Yeah, foreign body. Nice. What else? Group, yeah. Very epiglottitis. Anaphylaxis, yeah, we have a good list. Very good. So all these are good differentials. Group, epiglottitis, anaphylaxis, tracheitis. Very good. Nice. So you have a bigger list here, but we don't have much time. So you have access to the link. Probably Alana can share the link in the chat. But I think this is an important figure showing how infants are at higher risk of upper airway obstruction because of small airway. If you see, suppose you have the airway of 4 millimeters and you have 1 millimeter of edema, and you know that the resistance is inversely proportional to the radius to the power of 4. So with just edema of 1 millimeter, you are losing about 75% of the airway in children. While for adults, you are losing only 44%. So this is a big difference. So the smaller the airway, the bigger the decrease in cross-sectional area. So because of how the resistance is associated to the radius to the power of 4. Okay, I think this is important to remember. You can have the details on the link. Okay, so what are the following interventions which are effective in relieving upper airway obstruction? So in other words, what is the best way to manage that? Can I answer on the poll? I keep answering the question. We have 7 answers for now. So keep answering the questions. Eight answers. Very good. Yeah, we can stop the poll here, but most of the people got the right answer. So the right answer is F. All of the above may be utilized depending upon etiology of the upper airway obstruction. Very good. Yeah, this is a good picture showing a good position of the infant airway. Where we need to open the airway, we may use a shoulder roll and head rest to make sure we have the external auditory meatus at the level of the sternum. Very good. Yeah, this is just to remind us that the common etiology of lower airway obstruction include asthma and bronchiolitis. And this brings us to the next question. Which of the following interventions should not be utilized to relieve lower airway obstruction? So fluid resuscitation, bronchodilators, corticosteroids, and subcutaneous adrenaline. Yeah, I think we can stop there. So most of the people got the right answer, which is A. So there is no relationship between a really aggressive fluid resuscitation and decreasing lower airway obstruction. So subcutaneous adrenaline also lead to bronchodilation. So the right answer is A. The other question is, what are the 3 treatment guidelines for alleviating or for improving disorders of work of breathing? So what are the treatment? You can put the answers in the chat. I think I have sent like the preparation materials where you have the answers to these questions. So what are the treatment for increased work of breathing? Okay, Emmanuel, you can do positioning and oxygenation, suction. Okay. So what are the complication of increased work of breathing? So once you understand the complications, then you know how you can manage that. So people will have risk of fatigue and respiratory failure, and then you may need ventilatory support, for example. And some of the causes, they may have central nervous system causes, like poisoning, for example. You may need to give antidote. Or if you give too much drugs, you can use antidote as well, like naloxone, for example. Um, and you need also to avoid um, factors which can increase hypoxemia, including also hypercapnia and also hyperthermia. Okay, we can see the answer here. So for disorders of vocal breathing, you can minimize increased intracranial pressure by avoiding hypoxemia, hypercapnia, and hyperthermia. You may work on neuromuscular junction by providing ventilatory support, and you may manage overdose by giving individual antidote if known, and also contacting the poison control centers whenever they are available. So let's see for the next question, which was, how do you approach diseases of lung tissue? So as you can see, you can also consider ventilatory support, especially if there is pulmonary edema, increasing PEEP, and vasoactive support and diuretics. Very good. So let's see the update of our patient and conclude our discussion by the diagnosis of our patient. So you have already given 20 mL per kg of normal saline. You have given dopamine 5 microgram per kg per minute, and you changed your oxygen delivery to high flow nasal cannula, as we have discussed previously. We are giving 10 liters per minute, FiO2 is 60%. So the temperature is still 38.3, the pulse is 120, respiratory rate is down now to 24, the blood pressure is reasonable at 83/44, and the SpO2 has increased to 95%. Physical exam, you have bilateral conjunctivitis, but no discharge or scleroicterus. You have mild periorbital edema without erythema, and you have strawberry red tongue. You have mild intercostal retraction, but the suprasternal retraction are improving. You have wheezing, crackles, but no stridor, and you have good air movement. You have tachycardia and the regular rhythm. You have normal S1, S2, and there's no murmurs. So you have strong pulses now, and the capillary refill time has improved to below 2 seconds. So what is the diagnosis? So actually the diagnosis for this patient is a complication of COVID. So it's called multisystem inflammatory syndrome in children. So I will encourage you to read around this because it's a new diagnosis. So, and to be able to diagnose this, you need to have a pediatric patient aged below 21 years old, presenting with fever, laboratory evidence of inflammation. We have seen the CRP and ESR, which may be increased, evidence of clinically severe illness requiring hospitalization with multi-system involvement, at least more than 2 organs, including either cardiac, renal, respiratory, hematologic, gastrointestinal, rheumatologic, and neurological. So for our patient, there is cardiac involvement because of tachycardia and low blood pressure. There is also respiratory involvement because of hypoxia and tachypnea, for example, and the use of accessory muscles. There is also the hematological involvement because of the redness of the skin, and neurological because of decrease in GCS. When you have that, and without any alternative diagnosis, and on top of that, you have positive of current or recent COVID-19 infection, diagnosed by PCR or serology or antigen test in the last 4 weeks. So once you have those criteria, you may diagnose a multisystem inflammatory syndrome in children. So you don't have to memorize that. As long as you know that it exists, then you have the common criteria. You can also look them up. So there is no one treatment for this. So just supportive care and in ICU, aspirin, IV immunoglobulin whenever available, the steroids. There are additional resources as well for this on this topic, which you can find on Anesthesia Tutorial of the Week. So and that brings us to the end of the session for today. We can review our objectives and see if we have achieved them. And we'll answer a few questions before the end. So again, our objectives were to know various oxygen supply options in our setting, to know various oxygen delivery devices for pediatric patients, to be able to recognize SpO2 goals for various pediatric patient conditions, and understand and treat pathophysiological conditions leading to hypoxemia in pediatric patients, recognize hypoxemia during clinical exam, understand diagnostic considerations of hypoxemia in pediatric patient, be able to appropriately prescribe oxygen therapy for pediatric patient, and lastly, initiate appropriate management for hypoxemia. I hope we have discussed most of this. And if there are any questions, feel free to put the questions in the chat. We can find a few minutes to answer them. Thank you, Arana, for sharing all the links to the key materials for this session. In the meantime, Jean-Paul, feel free to give any comment or any additions.
Thank you, Eugene. You have covered the almost of this respiratory failure.
Can you raise your voice, please, or go like near your microphone, please, Jean-Paul? Thank you.
Yes, please. Are you getting me now?
Yeah, it's better.
Okay. I was saying that you've covered the almost of the most cause and pathology of respiratory failure in children. So honestly, what I can say, what I can advise to our fellows is that just they can keep reading, especially these resources, the link provided, so that they can get more knowledge and more understanding. And again, we are always there for them, for whoever who can discover any problem, they can feel free even to ask us after. So if any things they don't understand, they couldn't understand, maybe later in reading, so we are here, we are available, they can reach us so that we can keep giving some explanation. This is what I can say. You did a great job. You covered everything. Thank you.
Very good. So Arana, feel free to close the discussion and to give us the plan for next session. And if you can also talk about the certification for, yeah, thank you.
Yes, of course. Thank you everyone for joining today's session. We hope you will be able to apply what you've learned and encourage you to keep the discussion going by sharing any questions or thoughts in the WhatsApp group. The link to join the WhatsApp group is in the chat. All of the materials from today are also available on the Learning Resource Center. That link is also in the chat, and we encourage you to check that out for not just today's modules, but supplementary resources, videos, job aids, and more. As Dr. Eugene mentioned, there are certificates available for this course. If you attend live, you will receive an email shortly after, within the next 1 to 2 days. It will be a form where you fill in your name and your email, and a certificate for today's session will be sent to you. Finally, if you can please save this date on your calendar, September 25th. This is the date of session 9, where we'll be talking about obstetric considerations for oxygen and critical care. If you have any questions, feel free to message me on the chat here on WhatsApp, or you can also email us at echo@assistinternational.org. Thank you so much, Dr. Eugene, and all of your panelists, Dr. Jean-Paul today, for leading such an excellent session. And thank you to all of our participants for participating and sharing in the discussion. I'd also like to thank Project ECHO for making this program possible, and the Stanford team at the Stanford Anesthesia Division of Global Health Equity for creating these materials. We hope to see you next month. Bye.
Bye, everyone. Have a nice weekend. Thank you very much.
Bye. Thank you.
Thank you so much.